Hi everyone, today's topic is sarcoidosis. The pathognomic thing in sarcoidosis is a non-caseating granulomatous multi-system inflammatory disease, and the most common organ that is involved is lungs, which is present in 90% of the patients. And the male and female ratio are being equal. The age of presentation is 40 to 55 years. Etiology. Coming to the risk factors, the occupational exposure is one of the most important risk factors in sarcoidosis, especially the burning of the firewood. And also propionibacterium acne infection is also associated with sarcoidosis, and also CAD-G gene in Mycobacterium tuberculosis is also responsible for sarcoidosis. And coming to the histopathology, now we have seen that the pathognomic thing is a non-caseating granuloma, and the granuloma is it is going to have epithelioid cells, and these epithelioid cells fuse to form multinucleated gain cells known as the Langerhans cells. And along with this granuloma, we'll see certain inclusion bodies such as asteroid bodies and Schaumann bodies. These asteroid bodies are nothing but these are entrapped collagen, and the Schaumann bodies are the altered lysosomes of these epithelioid cells. And coming to the pathophysiology, we have spoke about the risk factor being occupational exposure, that is the burning of the firewood. Whenever such antigens enter the airway, these are being picked up by the antigen presenting cells, mostly the pulmonary macrophages and the type 2 epithelial cells. And these antigen presenting cells, they go present the antigen to the CD4 T cells. Hence, there will be recruitment of the CD4 T cells from the circulation into the alveoli, and this is usually known as lymphocytic alveolitis. And coming to the second phase is the granuloma formation. Whenever there is recruitment of these CD4 T cells within the alveoli, there is predominantly Th1 cell response. This is mainly because of the interleukin 18 that is being produced by macrophages, which are going to stimulate the Th1 cells more when compared to Th17 cells. And this Th1 cells are going to produce interleukin 2 as well as the interferon that is responsible for the granuloma formation, whereas this granuloma is being maintained by the tumor necrosis factor that has been produced by the macrophages. And coming to the granuloma resolution, as we all know that interleukin 10, which is an anti-inflammatory cytokine, is responsible for granuloma resolution. Hence, around 50% of sarcoid patients have spontaneous resolution. And the other thing that we are generally going to talk is these patients, usually 50% have spontaneous resolution and 20 to 25% patient have chronicity. And this chronicity especially depends on interleukin 23 and also the TNF. And around 5% of the patients have mortality, which is especially because of the interstitial lung disease. And this is the pathology that we have studied right now. And coming to the organ involvement, as we all know that the most common organ that has been involved in sarcoidosis is the lung, and the most common pattern is NSIP. But the catch point over here is the upper lobe is involved in this, and also apart from this, we are going to have traction bronchitis. Apart from this, you're also going to have the thickening of the bronchovascular bundle. And there is a SCADIC scoring system based on the chest X-ray. It's going to have 4 stages, that is stage 1, 2, 3, and 4. In stage 1, we have bilateral hilar lymphadenopathy. And coming to the stage 2, we are generally going to have hilar lymphadenopathy along with the pulmonary infiltrates. Here I'll talk about clinical paradox. Coming to clinical paradox, as we all think that whenever the hilar lymphadenopathy is decreasing, the patient should improve clinically. But in stage 2, the patients start presenting the clinical manifestations. This is because as the hilar lymph node size decreases, but there will be involvement of pulmonary infiltrates, hence the patient might present with wheeze and different pulmonary manifestations. And coming to the stage 3, they will be only pulmonary manifestations, and stage 4 will be fibrosis. Coming to the extrapulmonary manifestations, We also actually have to know that the sarcoid patients also have acute manifestations. The acute presentations being Loffgren syndrome. This Loffgren syndrome is usually a triad. Let's talk about a story. A 40-year-old female patient has come to an OPD with bilaterally symmetrical acute ankle arthritis with erythema nodosum, and this is all of a short duration, around 1 to 2 months, and this is a classical triad of Loffgren syndrome. And we also have a criteria versus criteria for this Loffgren syndrome, which usually involves age around 40, more than 40 years and duration less than 2 months, with bilateral ankle arthritis along with erythema nodosum. If either three out of those four features are present, then Loffgren syndrome can be kept as a diagnosis. And the other acute manifestation is the Heerfordt syndrome. This Heerfordt syndrome is usually we are going to have uveitis with parotitis in bilateral element type of seventh cranial nerve palsy. Whenever we talk of element type of cranial palsy, the things that we need to remember are, according to the infections, it might be diphtheria and also Lyme's disease. According to rheumatology, think of sarcoidosis and GBS need to be kept in mind. And this is all what we have spoke. Loffgren syndrome patient might present acutely with fever, with ankle arthritis, and also with erythema nodosum. And when we suspect this history, then we have to go with a chest x-ray, and the chest x-ray should have bilateral hilar lymphadenopathy. And Heerfordt syndrome is a uveitis fever. And the skin and sarcoidosis. This erythema nodosum, we can remember it with four P's. P for painful, the other P for pretibial, the other P is purple, and the other piece without pigmentation. The same type of erythema nodosum is also seen in Behçet's disease. How are we going to differentiate sarcoidosis erythema nodosum from the Behçet's disease? In sarcoidosis, there will be no pigmentation, but in Behçet's, pigmentation will be present. And the other skin manifestation is lupus perino. This lupus perino is a chronic inflammatory conditions where we have violaceous maculopapular rashes, which are usually seen around the eyes, nose, and also the cheeks. And the patient might also have certain nodules around the nose, and also mutilating lesions might also be present. In coming to the renal involvement, this renal involvement, actually the patients of sarcoid, the granuloma produces 1 alpha hydroxylase enzyme that is responsible for conversion of 25 hydroxy vitamin D3 to 1,25 dihydroxy vitamin D3, and that is responsible for increased serum calcium causing hypercalcemia. And this hypercalcemia is responsible for volume loss leading to prerenal AKI. At the same time, this hypercalcemia is responsible for afferent arterial vasoconstriction, and which is also responsible for AKI. And the most common renal manifestation is tubulointerstitial nephritis. And because the sarcoidosis might also have chronic tubulointerstitial disease, these patients may also have CKD. Because of hypercalcemia, there will be hypercalciuria, which leads to renal stones and medullary nephrocalcinosis. And coming to the cardiac manifestations, these granulomas may cause pressure effect on the conduction system, leading to conduction abnormalities, the most common being the AV blocks, and the patient might also have patchy myocardial necrosis, leading to dilated cardiomyopathy, and also pericardial involvement might also be present. The other organ involvement is eyes. Bilateral, symmetrical, anterior uveitis is the most common manifestation. Apart from this, we also have conjunctival nodule and also band keratopathy, and also we sometimes posterior uveitis might also be present, retinal vasculitis with optic neuritis. In the liver, the patient might be asymptomatic with just elevated alkaline phosphatase. Apart from this, they might also have intrahepatic cholestasis. Coming to hematology, they might be lymphopenia. Yeah, the thing is, because these granulomas are mainly surrounded with CD4 lymphocytes, they will be circulatingly low levels of CD4 T cells in the blood. Hence, lymphopenia is present, and these patients are more prone to infections because of decreased circulating CD4 T cells. And this is considered as immune paradox. That is, a patient with elevated CD4 T cells surrounding the granuloma but lymphopenia due to decreased circulating T cells presenting with more infections is an immune paradox. The other thing that we need to talk over here is as HIV patients usually have very low CD4 T cells, they can never get this disease, sarcoidosis. And the other thing is anemia of chronic disease might be present. And in sarcoidosis, hypersplenism might occur, leading to splenomegaly as well as pancytopenias. And the myalgias and arthralgias can also occur. The other causes of this bilateral hilar lymphadenopathy are TB, the malignancy, silicosis, allergic extrinsic alveolitis, and sarcoidosis. And coming to the investigations, we should do an EBUS along with lung biopsy to find this non-caseating granulomas. Apart from this, the other thing we need to do is we need to do a BAL and see the CD4 to CD8 ratio. If it is more than 3.5, that is very, very specific for sarcoidosis. And hilar lymphadenopathy, if it is more than 2 centimeter in the short axis, is more favor of sarcoidosis. And this gallium scan, which is not done nowadays. And coming to what is investigation. And what are the other new markers that are being used in sarcoidosis are serum amyloid A protein as well as soluble interleukin 2 receptor.